And this, of course, we will be discussing. I will not go into the details of this. That's what we are here for. And the theme is that the world cannot wait. And let me just
వాయిస్ రాదన్నావు కదా వద్దులే అసలు రికార్డు ఫోన్లో చేస్తుందేమో నువ్వు కూడా చూద్దు అని పనిచేస్తుంది
Hey, Manju, what happened? Thank you very much. I think with the short video which is being supplied by the World Health Alliance, everybody can access to it on the in the Google. And with this, I would request my colleague, Dr. Mithun Sharma, to go ahead and then tell us about the hepatitis B. Go ahead, Dr. Mithun, please. Dr. Mithun, you are not audible.
Am I audible?
Now, sir.
Yeah. So, good evening. So, I'll be talking on an approach to hepatitis B. So, I will basically walk through a case so that everyone can picturize how it really happens. So, this was a 10-year-old child who, on routine evaluation during a school screening program, was found to be hepatitis B positive. And the class teacher has just informed the family. So, the anxious parents visits the liver clinic to find out the course of the disease. They have a lot of anxiety. They don't know what's the next to do and what the future holds for this child. So, how do you approach a patient who comes to this clinic? So, we should always remember that there are a few steps which are very important. We need to confirm the hepatitis B. We need to recheck and re-verify. We should screen for what was the possible source of infection if anybody else in the family is affected. We find out whether this is a new infection or an old infection. Then the big question is whether the liver is affected or not. And finally, to find out whether he needs treatment or not. And if no treatment is offered, what is the treatment? What is the follow-up plan? So as per the guidelines, hepatitis B should be tested only by enzyme immunoassay or chemiluminescence immunoassay method. All other card tests don't carry much meaning and are not approved. So this is the method we use. And then once we are sure that this child or this patient has hepatitis B,
Children,
we always try to screen for the close family members. There are strict guidelines as to who needs to be screened, but for all practical purpose, all the household contacts, if it's an adult, the sexual contacts, patients who have ever injected drugs, any individual who comes to the clinic with a chronically elevated AST/ALT level, patient with hepatitis C and HIV, patient on renal dialysis, all pregnant women, any patient who is in need of immunosuppressive therapy for any reason whatsoever, and patients who are uncontrolled diabetic, these are what the ASLD guidelines say should be tested. So this child was retested and confirmed to be positive by an ELISA test. Both his parents were screened and found to be hepatitis B negative. And since their parents were also not vaccinated at any point of time, vaccination was advised for the parents. Now, the parents wants to know, did the child get this infection recently or was the child chronically affected? So we ordered some blood test which should be done for all patients. We advise a liver function test, and we do some tests which are related to hepatitis B. The AST/ALT levels were pretty normal. The hepatitis B DNA was done, which was pretty high, and he was found to be hepatitis B E antigen positive. And we did a fibroscan with a pediatric small probe and found that the liver was otherwise normal. Now, how do I interpret these values? So what does hepatitis B E antigen means? E antigen means that the wild virus is multiplying. When the E antibody becomes positive, it means somebody who was having a multiplying virus have seroconverted, which can happen at the rate of 5 to 10% per year. DNA tells us about the presence of virus. ALT tells about inflammation. The other two tests, that is quantifications and genotype, we are not doing in day-to-day routine clinical practice. So how do we interpret the results? So when somebody is hepatitis B negative, we do a core total. If it is negative and even anti-HBs is negative, it means that this is a person who is susceptible for infection and we offer vaccination. Now suppose this patient has a surface antigen positive, a core total positive, and anti-HBs positive. This is where most of us will fall. This means that this means that this patient had an infection in the past and is immune to natural infection. On the other hand, if a person has surface antigen negative, total also negative, but only anti-HBs positive, this is a person who has received vaccination. In this child, if it is hepatitis B surface antigen positive, total positive, and all other things are negative, it means that this is a chronic infection. And on top of that, if you have an IgM positive, it means acute infection, or it can sometimes be reactivation. And very rarely we see a situation where surface antigen is negative and total is positive. This is a very unclear picture, which could be old infections or a false positive or a low level of infection. So this chart is very important to understand how to interpret the results of hepatitis B serology. Now, hepatitis B has 4 phases traditionally. In the young age, the body does not recognize the virus as foreign, and therefore the body doesn't react to it. Therefore, the ALT is normal. This is called the immune tolerant phase. This usually occurs up to adolescence. Then suddenly one day the body can realize that there is a foreign body inside the body, and it tries to get rid of the virus. This is when the SGPT levels will rise. This has been traditionally called as the immune clearance phase. That is, the virus is trying to, the body is trying to remove the virus from the body. In this battle, which occurs inside the hepatocytes, ultimately the body is in most of the time successful in reducing the viral load, but they reach a consensus where there is no further reaction from the liver, and the patient goes into a carrier state. And later in course of the disease, even when they are seroconverted from E positive to negative, there can be reactivation. So these are the 4 phases which we have been traditionally taught in hepatitis B. In the first phase, the DNA is high, ALT is normal, no treatment is required. During the immune active phase, or the phase when the body tries to throw the virus, they are considered to be a treatment candidate. And when they become a carrier, this is where most of us get the patients in the clinic where they are E antigen negative, the DNA is low, ALT is normal. Again, they are not treatment candidate. And finally, in the later part of life, if there is a reactivation, when the viral level increases, the ALT increases, they become treatment candidate. So to be very simple, when somebody has an hepatitis B infection, nowadays we are getting away with the nomenclature of carriers, because this gives a false sense of security that a carrier can never get an infection. So the recent guideline says when somebody is positive, test him for E antigen positive or negative. In India, majority of the patients will be E negative. And then you classify them as chronic infection or chronic hepatitis. This is based on the principle that in chronic infection, the DNA levels will be low and the ALT levels will be normal. Whereas in chronic hepatitis, the DNA will be more than 2000 and the ALT will be elevated, and there can be some fibrosis on the fibroscan or ultrasound. E antigen positive adult patients we hardly see in our clinical practice, so I won't deal with this part of the algorithm. So this young boy had these reports. So this patient was in an immune tolerant phase, his DNA was high, but his ALT is normal, and therefore we decided not to treat him. And we asked the family to initially monitor the SGPT level every 3 to 6 months. And we told them that if any point of time the ALT increases to more than 70 for males and 60 for females, we will decide to treat. This boy was absolutely fine, and 7 years down the line, he suddenly developed jaundice one day, and his AST ALT increased to 650 and 200, and he was again E antigen positive. So what do you think is the natural history of this patient? Which phase is this? So his boy has possibly gone into the immune active phase where the body is trying to throw out the virus. At this point of time, there are 2 schools of thought. Some schools believe that you can let the body clear the virus on its own, or you can give medications at this point of time, which continues for usually a lifetime. If at any point of time there is an icteric flare, that is, if there is a jaundice, but then you have to treat it immediately. So this child became asymptomatic. He underwent LFT after a few weeks. Again, we see the AST/ALT came down. So this was the immune clearance phase. His E antigen became negative and antibody became positive. And we labeled him to be in a phase of inactive carrier, or what we now call it as E antigen negative hepatitis B infection. So this was the phase where this patient was. Finally, this boy went on, did his graduations, and then we told him to closely watch and monitor every 6 monthly his ALT, and do an ultrasound and an alpha fetoprotein, because HCC screening is required in this patient population. This boy went up and got a job, and then during a pre-employment checkup, one day he found that his ALT was again high. So DNA was more than 2000. This again brings us the question, which phase of the natural history do we think this patient is in? So if you go through this chart, you find that he has now become an E antigen negative chronic hepatitis B, or he is an E antigen negative chronic hepatitis B infection to a hepatitis. So he needs treatment at this point of time. So this is where we get most of our patients in real life practice. We will find patients who are E antigen negative, and the practical dictum that we follow, is that if the ALT is more than 2 times of upper limit of normal, which is not of the lab that we are using, but consider 35 for males and 25 for females, and if the DNA is more than 2000, or if the imaging shows fibrosis or cirrhosis, or if there is a very strong family history of hepatocellular cancers, these are the patients where we start treatment. So this is how we approach the patients. There are various guidelines. I have summarized all the guidelines in one table, but for all practical purpose, a DNA of more than 2000, an ALT of more than 2 times upper limit of normal, or if there is fibrosis, either on a non-invasive test or on a liver biopsy, which is recommended in many centers for people above 40 years of age, are treatment candidates. So finally, this is your chart. B antigen positive, see whether E positive or negative. Check the ALT. If the ALT is normal, just follow up. If the ALT is borderline between 1 to 2 times, you can repeat the liver function test a little early. If greater than 40, you can do liver biopsy. If there is more than 2 times, we treat. And a similar algorithm is for E antigen negative, which is mostly for Indian patients, where the DNA of less than 2000 is considered to be more like an inactive, but if it is between 2000 to 20,000 or greater than 20,000 for E positive, then we start treating these patients. I will not go into the details of the medications because it's a 15-minute talk. So for the shortage of time, this has just been how we approach a patient who comes to the clinic with hepatitis B positive and where we decide to start treatment. Thank you so much. We'll be open for questions.
Thank you. We'll take the questions at the end.
Yes, sir.
And many thanks, Dr. Mithun. You have clearly told us when to interfere and then when we should keep quiet and then keep on observing. Now we will hear from Dr. Anand Kulkarni. Unmute yourself, please. And he will tell us, a patient has come, there is acute hepatitis already, enzymes are elevated, how to go about. Of course, Dr. Mithun has already told us how to go about if it is a hepatitis B infection. Dr. Anand will tell us now about how to go about for the acute hepatitis. Go ahead, please, Dr. Anand.
Slides are visible, sir?
Yeah, slides are visible. Slightly raise your voice, that's all.
Thank you, sir. I would like to thank the Indian Medical Association and the Academy of Medical Specialties and our local team. And also like to thank Dr. P.N. Rao for inviting us to talk on approach to acute hepatitis. So I'll be discussing few cases and as well as the causes of acute hepatitis. To begin, inflammation of the liver lasting for less than 6 months is called as acute hepatitis. If the inflammation persists for more than 6 months, then we label it as chronic hepatitis. But hepatitis per se is a histological diagnosis. Clinically, we say there is acute hepatitis or chronic hepatitis based on the elevation in the liver enzymes. It is AST and ALT or the SGOT or SGPT. So this is the first case, a 19-year-old male. 8 days after eating outside, he presented with jaundice and abdominal pain for 48 hours. He complained of loose stools and fever around 5 days back. It subsided with the onset of jaundice. Clinically, he had icterus present and there was mild tenderness in the right upper quadrant. We got his basic labs. We said that total bilirubin was 4.7, direct of 2.8, AST 879 units, and ALT of 1,367. INR mildly raised 1.6 and ultrasonography showing mildly enlarged liver, otherwise normal ultrasonography. The first thing which comes to our mind in the patient of a young patient, history of outside intake of food, having initially loose stools, fever, then followed by jaundice, and with the onset of jaundice, there is disappearance of the fever. The first thing which comes to our mind is viral hepatitis in a young boy. And this is the season for viral hepatitis. We have been seeing lots of patients with hepatitis A related liver failures in our ICUs these days. So next we got is IgM-HAV and hepatitis E virus, HPSAG as a protocol, and IgM-HAV was positive. We labeled him as acute viral hepatitis due to hepatitis A virus. For this patient, we tend to monitor them for INR and a liver function test at least once in 3 days or 48 hours if the patient has any symptoms of encephalopathy. If the patient is an altered sensorium, he needs to be admitted definitely to the liver intensive care unit. We also tend to start them on NS-assisted infusion if the patient is admitted, or give some supplementary medications and supportive care for this patient. The normal advice for a normal diet and plenty of oral fluids. The basic reason for this hepatitis A has a little bit of atypical presentation. Most of these patients, though present with acute viral hepatitis or acute liver failure, they may have a protracted course. Some may have prolonged symptoms as well after the prodrome, and some, at least 5 to 10%, may also develop cholestasis, prolonged itching, and presence of pale colored stools in these individuals. So if you have a patient who presents later on after the initial symptoms, who has a fever, jaundice, then developing cholestasis later on, even then you may find that the patient has hepatitis A positive even later as well. Till 6 months you may have HIV, IgM positive. Till that time we can label him as acute viral hepatitis related cholestasis. There is subtle difference between acute liver injury and acute liver failure. The patient has only elevation of liver in jaundice and coagulopathy, which is this. So therefore, this individual, without any encephalopathy, we label them as acute liver injury. If supposing this guy had developed any altered sensorium, then we are labeled them as acute liver failure. The duration between jaundice, coagulopathy, and encephalopathy is variable. But up to 26 weeks, we consider it to be acute liver failure. But actually, some definitions also say about 4 weeks. So, second thing, this is the commonest symptom. This is the common virus and which is seen these days. Common symptoms include fatigue, nausea, mild fever, yellowness of eyes, that is jaundice, abdominal pain, and dark urine. Diagnosis based on the history and positive antibody tests. And LFT typically shows elevation in ALT more than AST. Treatment is conservative. For these individuals, strictly advised not to take any complementary and alternative medications which may increase the risk of liver injury. There are no dietary restrictions. Corticosteroids are not indicated for these individuals. Yes, hand washing and hygiene is important. Hydration is must. Monitor INR and look for encephalopathy in these individuals. So second case, this is also quite common scenario. We all get in our outpatient department. 38-year-old female who has history of PCOD. He is hypothyroid on treatment. There are no habits. Incidentally found to have liver enzyme elevation, routine evaluation. This was the LFT she presented with. Bilirubin was normal. ALT was 107, that is SGPT was 107. SGOT was 46. She got an ultrasound done in outside lab. It showed that there is an enlarged liver with a grade 2 fatty liver and mild evidence of PCOD as well. So this is a typical history which we see in our routine practice daily, where usually patients have been labeled as a non-alcoholic fatty liver disease. Not sure why The diagnosis is non-alcoholic fatty liver disease. This is also labeled as MAFLD, metabolic dysfunction associated fatty liver disease. And the recent guidelines label it as metabolic dysfunction associated steatotic liver disease. So this patient, if you see, I did not mention about the BMI, but BMI is must for all these individuals. The BMI is more than 25 and the individual has fat in the liver, it should be labeled as MASLD. The sugar, this is all the criteria which is commonly used for us in our laboratory to diagnose the patient of metabolic dysfunction associated steatotic liver disease. Sugar should be done, the fasting should be more than 500 or HbA1c more than 5.7. Blood pressure or treatment for hypertension, lipid lowering agents or plasma triglycerides more than 150, or HDL less than 40 for males or 150 for females, or lipid lowering treatment. We label them as fatty liver disease, or recently labeled nomenclature has been changed to metabolic dysfunction associated steatotic liver disease. So, but do not ignore all these patients who have fatty liver. You may be getting many of the individuals who present with fatty liver on ultrasonography, because there is all the prevalence in India is as high as 35%, and these patients can progress into steatohepatitis, where there is inflammation at least in 20% can progress to steatohepatitis. They can also progress to cirrhosis, which is the leading cause of cirrhosis. MAFLD is now the leading cause of cirrhosis. And HCC, liver cancer, can occur even in the absence of cirrhosis as well. If there is cancer, cirrhosis definitely has 2% risk, but NASH as well as fatty liver can also progress and develop liver cancer. Although there are multiple things which can modify this, that is genetic susceptibility, diet, gut microbiota, and environmental stress, but do not ignore MAFLD transient elastography is fibroscan, which we can get it done for these individuals to evaluate for evaluation of the fibrosis. Third case, again, 39-year-old male, chronic alcohol consumption for 8 years, almost 80 grams per day, presents with jaundice, loss of appetite, abdominal pain, and pedal edema. On examination, you can see several spiders over here. He has jaundice, pedal edema as well, tender hepatomegaly, spleen is palpable. Clinically, there is no ascites. In young individuals, we are noting that there is high incidence of alcoholic liver disease. And this is a classical patient who presents with significant alcohol consumption and having history of jaundice. So this is a case of alcoholic hepatitis. So lab variables for this patient had bilirubin 11 of hemoglobin of 11.5, TLC of 12,500. Platelets are good enough because this is not a chronic disease, so the patient has good platelets. Bilirubin of 9.8 and direct bilirubin of 6.7. AST 198, ALT 87. Ultrasonography demonstrating enlarged liver 19 centimeters with spleen of 12.1 centimeters and mild perihepatic fluid. INR of 2.1. So this is a classical patient who has alcoholic hepatitis. Why do we see this? One is history of alcohol consumption. Second is acute onset of jaundice. Third, this is the criteria to define an alcoholic hepatitis. 40 grams of alcohol per day for females or 60 grams per day for males for at least 6 months. So 6 months is sufficient to develop alcoholic hepatitis. The last intake of alcohol less than 2 months. The patient has jaundice accompanied by fever, malaise, tender hepatomegaly or any other decompensation and has a bilirubin more than 3 milligrams, AST more than 50 and the ratio of AST to ALT of more than 1.42. With the AST ALT not more than 400, it is definitely labeled as alcoholic hepatitis, which is the classical feature of this patient which we noted here. So any patient with alcoholic liver disease or alcohol use disorder, get an ultrasonography done, evaluate for get a fibroscan if possible, evaluate his liver function test, rule out other causes in the absence of any other history of alcohol intake, rule out for hepatitis B, hepatitis C, autoimmune markers in females especially, and ceruloplasmin in the younger individuals. Suspect advanced. If you suspect there is advanced fibrosis, get a complete liver function test, international INR, platelet and WBC counts, and endoscopy to look for varices. The common causes of acute hepatitis in our scenario includes infectious causes and non-infectious. Infectious includes hepatitis A, E, B, hepatitis C, dengue, CMV, hepatitis simplex virus, and EBV virus. Dengue, one classical feature is there is usually AST more than ALT. Otherwise, all the viruses have ALT more than AST. Non-infectious, commonest is alcoholic hepatitis, non-alcoholic steatohepatitis, autoimmune hepatitis, drugs, Wilson's, and if a patient has gallstones and there is a passage of stones, it can also lead to acute hepatitis. So what to do when an individual presents with altered liver function test? Take a complete thorough history of outside food intake, drugs, alternative medications, concomitant autoimmune diseases, look for autoimmune hepatitis, history of alcohol consumptions, examine for signs of liver cell failure. Investigations, commonest one is liver function test, ultrasonography of the abdomen, INR, check the platelet count, and fibroscan if available. Key points to remember in all these individuals: ALT more than AST in thousands, then viral hepatitis is the commonest trigger. ALT more than AST in 100 to 10 to 100s, it's fatty liver disease. AST more than ALT in thousands, it might be either drugs or the patient may have ischemic hepatitis, shock, which is usually seen in septic shock, or rhabdomyolysis. We had a patient who had presented with heat shock, because of the severe heat over here, he had presented with AST more than ALT elevation. He had rhabdomyolysis. AST more than ALT in hundreds, alcohol, autoimmune hepatitis, and drugs. These are the common trigger points. Thank you. Any questions? I'd be happy to take.
Okay, we'll have the questions at the end. Thank you very much, Dr. Anand. Then you have clearly clarified one, a viral disease, another alcoholic disease, another more importantly, non-alcoholic fatty liver disease. With this, we'll go on to Dr. Shantan and unmute yourself, Dr. Shantan. And then what he is going to tell us about, many a time, most of the times, the cirrhosis of liver is seen incidentally. When somebody goes for an endoscopy, there are varices are there. When goes for an ultrasound, there is a cirrhosis of liver is there. So how best we can first confirm a suspected early cirrhosis? That's what Dr. Shantan is going to tell us. Please go ahead, Rakshanthan. Your slides are seen
Okay, sir.
and you are audible. Go ahead.
Okay, sir. At the outset, I would like to thank IMA team members along with Dr. P.N. Rao sir to give this opportunity. So now the topic of discussion will be how to confirm suspected early cirrhosis. So coming to the slogan, currently one life, one liver. There's only one life and we have only one liver. Save your livers and save your life. So in brief, I want to just highlight the importance of this detection of early cirrhosis in form of a short diagram. This is a tip of an iceberg where patients will be diagnosed and symptomatic, where some of the patients are diagnosed and asymptomatic, but the majority of the patients are undiagnosed. So this undiagnosed patients group which are at most important for early detection to prevent the progression of the disease. So the outline of my talk will be based upon the following topics. So just as what is the difference between the normal liver and the cirrhotic liver? The normal liver shows no signs of scarring, and on the other side in the cirrhosis, the scar tissue replaces the whole of the normal liver tissue. There's a huge burden of cirrhosis, especially also present in India, where almost there are 20 to 30 deaths per 1 lakh. This is as per the latest guidelines which are there, which have been published. So coming to the etiology of cirrhosis, what factors and what are the causes which leads to a development of cirrhosis? Specifically mentioning the viral causes, the hepatitis B and C, the non-alcoholic steatohepatitis, as previously mentioned by Dr. Anand, which has been in detail, which is coming the leading cause of cirrhosis currently. There are other autoimmune diseases such as autoimmune hepatitis, primary sclerosing cholangitis, other chronic primary biliary cirrhosis, all leads to cirrhosis. Also on the other end, from pediatrics to the adult, there could be features of hemochromatosis and Wilson's disease which leads to cirrhosis. So coming to the stages of liver disease, in healthy liver, where some amount of fat deposition or some amount of inflammation leads to a hepatic fibrosis. This hepatic fibrosis and healthy liver are interchangeable and the patient can go back to the normal state with current precautions along with current treatment. But once the hepatic cirrhosis leads to cirrhosis, hepatic fibrosis leads to cirrhosis, there's severe scarring in the liver, it disrupts the liver function, and it's a one-way phenomenon. From the cirrhosis, many patients won't come back to the normal state, and hence, and this state of cirrhosis also leads to formation of cancers within the liver. Clinically, how does this show up? The clinical progression of liver disease, where in the pre-cirrhotic stage, where there is no fibrosis and the liver pressures are within the normal range. However, once the cirrhotic sets in, there is scars and fibrous tissues within the liver, and this leads to the increase in the hepatic venous pressure gradient, which is the portal pressure. There has been indirect evidence of portal pressure, and there once increase in portal pressures, there are other clinical signs which show up. However, from this stage, going to this stage, which is a decompensated stage, where the patient has lost the complete capacity of liver regeneration, and along with patient decompensated with the formation of ascites, varicose hemorrhage, and other complications leading to renal failure, jaundice, encephalopathy. And this is a stage where we need to act upon for early detection and prevent the progression, even if the patient is in early cirrhosis, and prevent the progression to the decompensated state, which is the later stage. Left untreated, this early cirrhosis will progress into the advanced stage, with leading to further complications, reducing the quality of life, and later on leading to death. So this is where we act upon from preventing the progression of this disease. How to prevent the progression? One is the early detection, the staging of disease, the removal or treatment of the etiological factors, diet, exercise, physical rehabilitation, and the vaccinations to prevent recurrent infection. So when to suspect liver disease or when to suspect early cirrhosis? The common signs which the patient present with. One is the weight loss. Patient might present only with the persistent weight loss. The other major common complaints which a patient come up to the OPD is a pain in the right hypochondrium or the discomfort in the right hypochondrium. Patient might be having persistent nausea or vomiting. Patient might be having, in patients with viral hepatitis, and patient with alcoholic hepatitis, patient can come with yellowish discoloration of skin and sclera. Patient come with dark urine, and some patients might present with epistaxis. Also, the one more major symptom which the patient presents is a fatigue and loss of appetite. Majority of the patients in the early stage come with only complaint of fatigue, loss of appetite, nausea, abdominal bloating. Also, when seen in few the clinical detailedly, the patient, you also can see the swelling of feet, ankles, and legs in terms of pedal edema, and there are other signs which can be examined for detection of cirrhosis. The clinical signs of the suspect early liver cirrhosis, one is the hepatomegaly, and along with a firm liver on the examination. There will be patient with splenomegaly, where the enlarged spleen. On correct examination, we can appreciate the splenomegaly. In some patients, there will be hypoalbuminemia, severe hypoalbuminemia leading to leukonychia. This is a patient which presents with cirrhosis. Increased bilirubin, which are icteric, which can be seen on clinical examination. This is a spider angiometer, which is mostly seen in patients with alcoholic liver disease, because of the hyperestoronism, previously shown by Dr. Anand, patient present in the SVC territory. Unexplained coagulation abnormality and unexplained bruises, which are seen all over any part of the body. The other thing is a pedal edema, which can be appreciated in a patient might present with only pedal edema as a complaint. On the advanced stage, where we can see also the Dupuytren's contracture, comparing the two patients where the Dupuytren contracture, and along with a subtle sign of thenar atrophy or the small muscle wasting also can be seen appreciated in patients with liver cirrhosis. One more, the common sign is a fetal hepaticus. So whenever a patient comes saying that he has all offensive smell breath, so we have to be worried about and we have to be worked up for liver cirrhosis. So what are the tests to confirm the cirrhosis? There are two types. So what is the invasive test and the non-invasive test? The invasive test is a liver biopsy, which is a gold standard, and there are other non-invasive tests. What is the problem with the biopsy? Even though it is a gold standard, it is an invasive procedure needing hospitalization. It requires expertise to perform the biopsy, carries a definite risk of serious complications such as bleeding. Patients are unwilling to undergo the procedure because it's invasive. There's large amount of sampling error might be there if the sample is not picked up properly. There is inter-observer variation between the pathologists. Repeated measurements are difficult, and hence a need of simpler, non-invasive, observed independent and repeatable tests are needed in place of the biopsy. So the further non-invasive assessment, there are indirect tests, the imaging and the specialized tests. The indirect test, mainly the hemogram, especially we need to look at the platelet count. Thrombocytopenia is one of the important feature and is a starting feature where patient might progressing to cirrhosis that is already cirrhotic. So keep a watch on the platelet count. The biochemical test, the ALT, AST and the albumin. So the albumin being a synthetic function of the liver, in patients with cirrhosis you find a low albumin. Also the composite scores, which I will be mentioning later, which is the PIP4, APRI and the fibro test, are useful in assessment of early cirrhosis. Imaging, the ultrasound, CT, MRI, and there are specialized tests such as endoscopy and elastography. So what are the advantages of these non-invasive tests? First, it is easy to perform. It is free from complications. There is widespread availability. It can be done in an outpatient setting. It's a bedside test also. They are cheap, do not require any specialized training. And there is always a homogeneity in this test because their automatic measurements of their component variables are there. There's a lot of homogeneity among all the tests. And along with, there are few tools for automated computation of score currently available, such as apps which can be done on bedside and OPD based clinic, and easy to repeat at frequent intervals, and can also compare with the changes in the treatment and the changes in the diet and exercise. We can compare the amount of fibrosis and change in the scores also. So coming to the first non-invasive, which is the USG ultrasound abdomen. So ultrasound abdomen, on ultrasound, the things which we need to look at is one is a small or any shrunken liver, the nodular surface with any irregular margins. There's enlarged caudate lobe or volume distribution which is there on ultrasound. There's coarse ecotexture of the liver. Also, along with the identification of cirrhosis, we need to see the features of any portal hypertension, such as the enlarged spleen. There's dilated portal vein, a diameter of greater than 12 mm is significant of dilated portal vein, and presence of a venous collaterals. Also, the complications associated with the cirrhosis, such as the ascites, can be seen in the ultrasound. So, in this ultrasound, which we see the normal liver and the cirrhotic liver, where it is irregular, the nodular and shrunken liver. Also, in this patient, which is a low probe frequency probe, where we can see the surface of the liver is irregular and nodular when compared to the normal surface of the liver, which is smooth. Also, the caudate lobe in this picture, which can be seen in the patients with cirrhosis, there is hypertrophy of the caudate lobe. Also, the flow, the portal flow, which is important in patients with normal patients, there will be normal forward flow in the portal vein, whereas in the patient with cirrhosis, there is this, in advanced stage where you can see a centrifugal flow, this abnormal reverse flow which we can see in the portal vein. The other commonly used non-invasive tests which can be calculated, these are composite scores such as the APRI, where the components of AST and platelets are taken into consideration, and one more is a FIB-4 score with where age, AST, ALT and platelets are taken into consideration. This can be done normally with the normal routine blood test which we do for the LFT and the hemogram itself, and these are very cheap and can be taken as a substitute for the fibrosis or for the cirrhosis. The other thing is a fibro test, where other high-level investigations are needed, such as the haptoglobin, the alpha-2 macroglobulin, which are generally not done, and these are specialized tests at designated laboratories. The other non-invasive test is a fibroscan, which is also called transient elastography. So it needs a dedicated equipment, and the cost is little higher when compared to the prior tests. So the non-invasive tests also include the ARFI and the shear wave elastography. This ARFI stands for the acoustic radiation force impulse. This is incorporated, it is a software which is incorporated into the ultrasound itself, and the specified location in the liver can be selected, where without vessels or without any space occupation lesion, the space in the liver can be selected, and further the fibrosis or the shear wave velocity can be estimated in this technique. Also, coming to the transient elastography, in transient elastography, the transducer, it sends a mechanical shear wave, and this is on the screen. It shows the LSM, which is a stiffness measurement which can be seen, which is on the screen. So this stiffness indicates the fibrosis. There are dedicated cutoff values as reference which are given with the different etiologies. With the significant fibrosis, the etiology, based on the etiology, the F3 and F4 has to be seen, where F4's dedicated values which have been proposed for hepatitis B greater than 12 is labeled as a cirrhosis. With the hepatitis C, it's also 12. With patients with NAFLD and NASH, any value, LSM value which is more than 14 is labeled as cirrhosis and can be used for the detection of cirrhosis. What are the advantages and disadvantages of transient elastography? So it's easy, non-invasive, can be done in outpatient community settings. It takes less than 10 minutes to perform, and healthcare staff can be easily trained. However, the limiting factors is a high cost of equipment, and it needs regular maintenance or calibration. There's no universal cutoffs for specific stages of fibrosis. This F3, F4 is labeled, but a borderline of F2 and F3 there's no universal cutoffs. And in very obese persons, it is difficult to measure with transient elastography. So coming to the composite score, which I've been mentioning before, which is the APRI, which is AST to platelet ratio index, where you take the AST level and the upper normal limit of the AST, divide by the platelet count into 100. You also have a calculators online where you can calculate the APRI. The FIB-4 is also utilizing the age, AST, platelet and ALT with a formula. This cannot be done manually, and we have many calculators online, and this FIB-4 calculator can be used to measure the fibrosis. There are also cutoff for significant fibrosis or cirrhosis has been mentioned. For APRI, a low cutoff of 0.5 has been mentioned and a high cutoff of 1.5. A lower cutoff has higher sensitivity, it rules out cirrhosis, and a higher cutoff has higher specificity and rules in cirrhosis. So any value more than 1.5 or more than 1.5 or more than 2 for the APRI, and a FIB-4 more than 3.25 highly suggestive of cirrhosis, and any value which is less than 1.45 in FIB-4 and less than 0.5 in APRI, it shows that the patient does not have cirrhosis. So coming to one case scenario where a 60-year-old male with an HCV infection has a platelets of 88,000 and AST of 58 with upper normal limit of 30. So what is the stage of liver disease? It's a bedside investigation. When you calculate the APRI, it's coming to 2.2 with a cutoff index of more than 2, rules in cirrhosis. So the patient can have a significant fibrosis and further has to be referred to a hepatologist. So there are further other non-invasive tests for assessment of fibrosis and cirrhosis as mentioned before, and there's also one more test called enhanced liver fibrosis test, and which needs a further specific component. So when to refer to a hepatologist? What is an ideal case of NASH or NAFLD? Early detection is the key. So when you identify the patients at risk, with 2 or more metabolic factors and type 2 diabetes or steatosis, and you do the history and laboratory examination, you always do for non-invasive testing for these patients with a FIB4 being taken consideration, the FIB4 less than 1.3 or more than 2.67. 2.67, the high risk of patient having cirrhosis, hence refer to a hepatologist immediately. However, if it is intermediate risk, you can do a liver stiffness measurement such as the fibroscan, and in a patient having an LSM 8 to 12 or more than 12, it's better to refer the hepatologist because identification of other complications and immediate treatment is required to prevent the progression into a later stage. So in summary, I'd like to highlight that it is important to assess the presence of significant fibrosis or cirrhosis, especially in patients with HBV, HCV and NASH. It influences the treatment and response to treatment and prognosis. Liver biopsy, although it is gold standard for assessing fibrosis, but has several limitations. So in many simple and easily available non-invasive methods are available and fairly reliable. APRI is the most widely used, easy to calculate and validated. However, FIB4 can also be used in the community settings. So coming to the first slide, which I will mention, the diagnosed symptomatic. So undiagnosed patient, which are the priority now with the primary care physicians. However, the ocean which is seen is the non-affected patients, where the prevention is better than the cure. So how can you prevent? You avoid alcohol, regular screening for hepatitis B, C, vaccination for hepatitis B, diet and physical exercise, and early detection is the key. So coming to World Hepatitis Day, so now we are not waiting and everyone has to get tested for hepatitis and to protect you and your family. Thank you.
Thank you very much. Please unshare your slides, please. Thank you for all the speakers, my colleagues. With this, we'll go on to some kind of a rapid questionnaire. We have got 4 questions on behalf of all of you. I'll be asking the questions to the experts. Let them see what the answer is. First, I would like to ask Dr. Manasa. Dr. Manasa, you are there? Right.
Yes,
okay.
sir, I'm there.
Okay, sure. Thanks. See, A, B, C, E. We have not talked about D so far. You can just mention about that one.
Yes,
and what is the basic difference between these A, B, C, E?
Yes, sir. Can I? I'll just share my slides right now.
Please do.
There's a small glitch, sir. Just a second.
Okay, no issue.
Yeah. Meanwhile, I think we have a question, sir.
Okay, actually, you can use your slides.
Yeah.
Right. Thanks. Go ahead.
Yes, sir. Yeah. Coming to the first slide, basically, let's understand what the term hepatitis means. It means inflammation of the liver. And hepatitis can be caused by various other causes other than viral hepatitis. Causes like heavy alcohol, autoimmune, drugs, toxins, all these can cause inflammation of the liver. However, the most common cause remains viral infection. And hepatitis A, B, C and E remain the most common causes. And they cause from mild and self-limiting infections to very severe illnesses. The inflammation, if it is less than 6 months, it is termed as acute. And if it is more than 6 months, it is termed as chronic. Next slide, yeah. So, in this figure, we can see the virion. And hepatitis A and E, it is a naked virus. There is no envelope around it. And hence, this is the virus, this is a virion which can be isolated from the stool and feces. And this is a quasi-enveloped virus, which is again seen in A and E. And this is a virus which can be isolated from the bloodstream. And a conventional enveloped virus will be seen in hepatitis B and C. Now, coming to the differences between various viruses, hepatitis B is a double-stranded DNA virus and it is an enveloped virus, whereas the other viruses, that is hepatitis A, C and E, are single-stranded RNA viruses, and there is no envelope for hepatitis A and hepatitis E virus. And hepatitis A belongs to the family Picornaviridae, and hep B belongs to Hepatinaviridae, and hep C belongs to Flaviviridae, and hepatitis E belongs to Hepiviridae. And the route of transmission is feco-oral for hepatitis A and hepatitis E, whereas parenteral route of transmission is seen with hepatitis B and C viruses, and vertical and sexual routes are also present for hepatitis B. And there are no carrier states for hepatitis A and E virus, whereas carrier state is common for hepatitis B virus and it can also be seen in hepatitis C. Incubation period is similar for both hepatitis A and hepatitis E, which is between 15 to 50 days, whereas the incubation period is 50 to 180 days for hepatitis B and 40 to 120, that is almost around 4 months for hepatitis C virus. Chronicity can be seen in hep B and hep C, and most commonly children are affected in hepatitis A and young adults in hepatitis E, whereas adults and of any age can be affected in hepatitis B and C viruses. Next slide. So coming to the differences between hepatitis A and E, which are both don't have an envelope with similar incubation period, and hepatitis E virus can also affect adolescents, that is genotype 1 and 2, young adults, whereas genotype 3 and 4 will affect middle-aged and elderly men. Asymptomatic infection can be seen in both the viruses, cholestatic features can be present, but relapsing and remitting features will be present in hepatitis A but not in hep E. And persistent infection not seen in hepatitis A, but it can be seen in hepatitis E virus, especially in genotype 3 immunocompromised patients. Acute liver failure, although seen in hepatitis A, is usually rare, and it will be seen in hepatitis E with up to 25% mortality. Coming to the extrahepatic manifestations, neurological manifestations are rarely seen, and in the form of meningoencephalitis, mononeuritis multiplex in hepatitis A, and neuralgic amyotrophy in hepatitis E virus. Rash is rare in both. Myocarditis may be seen, and features like arthralgias and myalgias can be seen in both the viruses, and renal manifestations in the form of glomerulonephritis can be seen, and GI manifestations in the form of pancreatitis, mainly for hepatitis E, it has been described. And hematological manifestations, as we can see in our practice, especially in G6PD deficient individuals, there is accelerated rate of hemolysis. And hepatitis E can also cause thrombocytopenia, monoclonal gammopathy, and cryoglobulinemia. Next slide. And coming to hepatitis B and C differences in particular. So when we come to hep B, when the infection is seen in adults, there is a 95% clearance rate, and chronicity and progression will be seen in only 5%. Whereas if the infection is during neonatal period and vertical transmission, there is only a 10% chance of clearance, but whereas the chronic progression rate will be up to 90%. And coming to hepatitis C, there is a clearance of about 60 to 80%, and chronic progression will be seen in 20 to 40% of individuals. And the mechanisms of immune evasion in the form of involving CD4 cell inhibiting factors like IL-10 and TNF-beta are seen in both hep B and hep C. And a short note on approved therapies. Nucleoside analogs, pegylated interferon have been used in hepatitis B, whereas ribavirin and directly acting antivirals can be seen in hep C, they have been used. And which is the treatment group? The treatment initiation decisions, as we have discussed, it will be based on presence of cirrhosis, ALT levels, and hepatitis B DNA levels. And that selection will vary based on the genotype, presence of cirrhosis, treatment history, and immunocompetency state in hepatitis C. The goal of the therapy in hep B will be to achieve disease suppression, and whereas in hep C will be to eradicate the RNA and attain SVR. And the global prevalence of hepatitis B is around 400 million, which is very high compared to 170 million in hepatitis C. And chronicity again much higher in hepatitis C infections. Now coming to a short note on hepatitis D virus, which is an RNA virus, and majority of the patients usually, if it is a simultaneous infection with hepatitis B, it is a self-limited infection. But however, if it is a super infection on Hep B, it will be a more severe acute hepatitis. And majority of these patients will have chronic hepatitis D virus infection. And how do we differentiate if it's a super infection or a co-infection? In a co-infection, IgM anti-HBC will be positive, whereas in a super infection, it will be negative. And in those individuals co-infected with HDV and HBV, they receive treatment with pegylated interferon will be the treatment. And oral nucleoside or nucleotide analogs, they have limited or no efficacy and they are not useful in these individuals. Thank you.
Thank you. Thank you. Thank you. Please unshare. Thank you. We'll have the questions at the end. And now the common scenario is that during pregnancy, normally the test for these tests, HbSAg is also one of them. And one of the common things, which people are afraid also at the time of pregnancy, as you know, that HbSAg is positive. In fact, it shatters the entire family. And there's nothing to worry actually. We did not worry at all. And this what about Dr. Soumya will be telling us. 6 weeks pregnant, and then she is detected to a HbSAg positive routine investigation. How to go about? Over to you, Dr. Soumya.
I hope my slides are visible and I'm
Yes, you are visible. Yes, your voice is good. Go ahead.
At the outset, I would like to thank IMEMS and P.N. Rao sir for giving me this opportunity. So any pregnant female who comes with 6 weeks of gestation and incidentally detected HbSAg positive status indicates that for all practical purposes is a chronic hepatitis B infection, and most of my slide and discussion will be about chronic hepatitis B in pregnant females. And it is common to get a patient in early pregnancy because the screening for hepatitis B surface antigen is mandatory as per WHO guidelines and NHM guidelines in the first prenatal visit itself. So why is it so significant to discuss the scenario of hepatitis B surface antigen positivity in pregnant females is because this pregnancy is a state of altered immune activity and it affects the natural history of hepatitis B, and there will be increased risk of hepatitis B infection flares during pregnancy